Most of the population has experienced motion sickness at some point in their lifetime. Dizziness, nausea, and vomiting while in a car, plane, boat, or some other moving vehicle isn't a foreign concept. Most people address this issue with non-prescription antihistamines such as Dramamine, or if that doesn't work, simply avoid occasions where they may find themselves motion sick. What most people don't know is that they can use physical therapy to decrease and manage their symptoms. So who is our population? The U.S. National Library of Medicine cites that 1 in 3 people are genetically predisposed to highly symptomatic motion sickness, and that everyone can experience this phenomenon if the stimulus is high enough. There are populations that are more susceptible, however. Women are more likely than men, and children are more likely than adults. People who already have an underlying balance disorder or migraines are also more susceptible to these symptoms. Most of the susceptibility, however, is related to genes. A study conducted in 2006 shows that twins often have a very similar symptomatic tendencies to motion sickness when put through a series of motion situations. However, common motion sickness is a complex syndrome that includes many body systems and can affect people's functional ability and disrupt their daily lives. So what is motion sickness? One study defines motion sickness as a set of autonomic symptoms caused by incongruent sensory impressions under conditions of motion. Some of these symptoms are cold sweats, pallor, nausea, and vomiting, and are caused by a stress reaction due to motion. We have 3 main sensory channels that send information to our brain about body posture and body movements: the vestibular, visual, and proprioceptive. In the vestibular apparatus, the semicircular canals are stimulated by angular acceleration. The otolith organs are stimulated by linear acceleration. Visual input provides information about the body's own motion and the motion going on around it. And proprioceptive information from joints and skeletal muscles send information about joint position, joint acceleration, and body movement. There are 2 theories that are widely accepted as the cause of motion sickness. The main one is the sensory conflict theory, which we will examine, but we will also briefly review the postural instability theory. So the sensory conflict theory. This is the most current and widely accepted explanation of motion sickness. This can happen when there's a conflict in the sensory information regarding orientation and movement sent from the vestibular, visual, or proprioceptive channels. There are 6 main conflicts that can happen. So in a Category A conflict, the vestibular and visual information is conflicting. An A1 conflict is both systems report motion, but they disagree temporospatially. An example of this is watching waves over the side of a ship. An A2 conflict is the visual system reports motion, but the vestibular does not. An example of this would be watching a movie of motion and feeling sick even though your body is still. An A3 conflict conflicts the vestibular system that reports motion, while the visual system does not. An example of this would be reading a book in the back of a car or under the deck of a ship. In a Category B conflict, there's a conflict between the information in the vestibular apparatus. In a B1 conflict, both report motion, but they're conflicting motion. An example of this would be nodding your head while spinning in a chair. In a B2 conflict, the semicircular canals are stimulated, but the otolith organs are not. Example would be head movements while being weightless, possibly in space. Astronauts may feel this. In a B3 conflict, the semicircular canals are not stimulated, and the otolith organs are stimulated. This is very rare and can be stimulated in lab conditions with the body being horizontal and being turned on its long axis. So, postural instability theory. Most journals mention it as a part of motion sickness phenomena, but there's not enough information and studies done specifically on this theory that would support it as a main cause. One study I could find was done on postural instability preceding motion sickness, and the degree of motion sickness being proportional to the amount of postural instability. The study was done by controlling for postural instability with restraints while in a sensory conflict situation. This study showed that there was no significant difference in the reported sickness of the restrained versus unrestrained groups. We will focus mainly on the sensory conflict theory to guide the basis for treating motion sickness with physical therapy. As you can imagine, if following the sensory conflict theory, it is beneficial to find out which conflict is happening. Unfortunately, there's not an abundance of literature on physical therapy testing and diagnosis with motion sickness. So we will follow a case study about how one physical therapist managed to figure out which sensory conflict was happening for his patient and how he chose to rehab it. The patient was a 34-year-old marine biologist whose symptoms aboard a ship had gotten increasingly more severe and lasted longer, even hours, after on dry ground. It was beginning to limit her ability to function in her daily life by means of nausea, vertigo, and lightheadedness, as well as her ability to work on a boat and scuba dive. She was diagnosed with motion sickness by a PCP and referred to PT. To start testing, he tested general functional ability, balance, coordination, vision, and the vestibular system. He tested posturography, dynamic perturbation testing, heel to shin testing, and finger to nose testing, which were all negative. To test for positional vertigo, the Dix-Hallpike test for BPPV and rotary chair test was performed, which both were negative, no nystagmus, and no onset of motion sick symptoms. These negative tests indicated to the PT that the peripheral vestibular system was intact. Next, he examined static and dynamic visual acuity testing. Symptoms were exacerbated with head movements during the dynamic testing. When a test was given to hold a card at arm's length and moving it from side to side while trying to read the letters, symptoms were onset within 30 seconds and the patient had to sit, became flushed, and reported vertigo. Symptoms continued for 10 minutes. When the test was given to keep the card still but move the head, there was a mild onset, but nothing as severe. To confirm this diagnosis and further identify the provocative symptoms, the dynamic visual acuity test was repeated with somatosensory information compromised. The patient was asked to stand and march on a foam mat while turning head left and right and try to focus on small letters on a card 10 feet away. While performing this test, the patient began sweating, required assistance to prevent a fall, and reported severe lightheadedness and nausea. Based on the testing, the PT diagnosed her with visually evoked motion sickness with somatosensory preference. For this patient, the interventions included progressions of visual vestibular habituation exercises, dynamic balance training with progression of speed and postural control. Following these progressions, by the week 10 follow-up, the patient could complete all exercises with no difficulty and experienced no dizziness or when driving, and only experienced mild lightheadedness after scuba diving for 4+ hours. Although this case report is not detailed on the progressions or how exactly improvement was achieved, the treatment was based on the sensory conflict theory and keeping it stimuli specific. Diving a little deeper into the general interventions, the main intervention categories are habituation and patient education on reducing a conflict and synchronizing visual systems with motion. Habituations. Introducing different stimuli with gradual progressions can habituate these systems to be less sensitive. A couple specific examples. This can include challenging the visual system by holding a card or popsicle stick at arm's length, moving it left and right while keeping your head still, or keeping the card still and moving your head and eventually progressing to both moving at the same time. One case study showed that a 33-year-old woman who got nausea while working on her computer and in the car started physical therapy where they did eye motility exercises. She visually tracked a moving ball in all directions 30 minutes a day for 17 days. She started this with her head still and then progressed to moving her head into lateral flexion and rotation with the ball. It is ideal to get something large moving in the patient's horizon. One PT has used moving optical illusions on a projector as a background to stimulate that in a clinic and has done some of these progressions against this as a background. These are just some examples of how to challenge these different systems. Another way we can treat this is using patient education on how to manage symptoms as they come. This would include focusing on the horizon or distant point and minimize head movement while in a moving vehicle, or synchronizing the visual system with movements such as tilting the head into turns or taking over steering or control if possible. Breathing techniques are also always good for these patients. In conclusion, there is a whole new population we can capture and help with physical therapy. Much more research needs to continue to be available, but we can still make a difference in these people's lives today.